Thank you. It's a real pleasure to be here, and I know the least about MS of anybody who stood here today. I know quite a bit about commissioning, and I just want to frame the short answer to this question is no, and the slightly longer answer to the question is no, because I think it's more about what you do, and I think it's more about how you understand politics in the way that health services is commissioned. And the slightly longer version of all of that will follow. I work for Moorhaven Associates, which it means I work for myself, for full disclosure. That means I work for myself, and it means that I live in a converted mental asylum on Dartmoor. That's what that title means. That's quite interesting to me because next door to me, somebody sleeps in the bedroom where there used to be an ECT suite, and across the way from me, somebody sleeps in a bedroom that used to be the mortuary. And change happens really, really slowly when you watch it going forward, and it happens really, really quickly when you watch it going back from when it's happened. And that celebration of the journey you've made, that somebody has encouraged you to think about, stood here, is my kind of life now in strengths-focused development with teams and individuals about remember what you've got and build on what you've got. I am here because I have been a chief exec and finance director in the NHS since before this millennium started, and I know a bit about commissioning, but really I'm here because in Jeremy Hobart I have a friend and a colleague that I work with who is one of the most committed people I've ever met in healthcare, and he's the reason that I'm not staring at the beautiful view of Dartmoor today, but I'm here because I work with him and his team on this proposition about what's the best thing that you could do to improve the quality of the service that you offer. And he gave me permission to say this, so just so you know, I'm not breaching a coaching confidence as I tell you this stuff. The most important thing you can do is change what you do first. And lead yourself before you lead your team, and lead your team before you lead your organization, before you try and lead a system. The utter chaos that you find yourself in, Jeremy, is mostly created by you. And if you want to change it, the biggest thing you can do is change what you do. And remember that you are the apex of this most amazing system that delivers quality of care to people in the southwest. Doesn't mean you should be thinking about how we employ temporary staff over the summer. You should be thinking about how that system works for the benefits of patients, and that's the journey that we are on. The journey for the team, some wonderful people that I recognize in the audience who I haven't got permission to tell you embarrassing stories about, their number one issue to improve the quality of care is they have two consultants who operate differently and do different things. Their number one identified issue, if they want to solve this problem about variation. My journey to variation, I was chief executive in Yorkshire at one point, looking at dialysis rates across York and Harrogate. Somebody was trying to make the case to me to put some money into a new dialysis centre in Harrogate. And it was a marginal case about demand. And when you look at all the figures and the data, what I didn't realise, and still brings me up short to this day, if you lived on the other side of Harrogate in the North Yorkshire Moors, your rate of dialysis is half, 100% variation, half the rate of dialysis living in the centre of York next to the dialysis centre. What that means is people choose not to travel and to die rather than have dialysis treatment. And our job to provide a centre was to get people a better choice, because people make strange decisions about their healthcare if you don't think about how you provide them service. That's the end of that story. If you live in York, by the way, and you've ever been to the Independent Sector Treatment Centre in York, I signed the contract on that building. It's one of the least impressive things I've ever done, and one of the most impressive things I've ever done in commissioning. And I hope if I remember to come back to it at the end, I'll tell you why. For full disclosure, as well as working for myself, I do a lot of work with Optum, who are the part of the biggest healthcare company in America, United Health Group. That's for the sake of full disclosure, and because my dad always told me to tell the truth. He taught us that society is judged by how we look after the most vulnerable, and I've chosen to work for a big healthcare company in America, which I'm not sure he approves of all that much. So if the short answer is no, I want to tell you the slightly longer answer about commissioning. Commissioning is how you understand the difference between cleaning your house and getting a cleaner. It is no more complicated than that. That's what commissioning is about. And it sounds really easy until I don't have a cleaner. I'm imagining this situation. But it sounds really easy until your cleaner says, and how often do you want me to wipe the skirting boards? Wipe the skirting boards? What are you... And because if you want to do that, you actually have to start to think about how you create a specification for the thing that you do innately, that you are the specialist in. How would you create a specification for doing it? And of course, that sounds relatively easy because I can come up with a number for how often to clean the skirting boards until I tell you there's a regulator of house cleanliness in this country who makes standards. And eventually, I'm going to have an argument with my cleaning company about whether they respond to me who pays their bill or they respond to the regulator who tells them how a toilet should be cleaned. And commissioning becomes complicated because in that very simple process, if I give you 100, you are responsible for cleaning 100 houses, you will soon have a commissioner because you can't oversee cleaning of 100 houses and you're not going to rely on the cleaning company. So you need a commissioner, somebody who takes responsibility for the resource we have for cleaning all those houses and the company who's going to oversee that cleaning. And that's why commissioning exists, because you as taxpayers want somebody to make sure that we're not wasting money. And it's really easy. So here you go. If you live in any of the big areas here, this is made up. This isn't true. So anything I say from this point on that feels like I'm being controversial is embellished for effect. If on this slide here, you have got to make sure that 95% of the people who live all over this beautiful rural area in Devon get an ambulance within 8 minutes. That's your job as a commissioner. And it's really simple because people in Exeter and Plymouth and Torquay and Paignton, in fact, the things that are named on here all get that already. Brilliant. They're getting 98% of ambulances turn up on time. And we've got one extra ambulance because somebody's giving you a bit more money and you as a commissioner have decided. All the other dots don't achieve that target. Where do you put your ambulance? And it's a really easy question because once you've been in commissioning for long enough, it hits you in the face so quickly, you stick it in the middle of Plymouth where they have already the highest achievement of ambulance response times. Well, of course you do. And you do it, and you think that makes me bad, but you do it because actually that's going to impact the most number of people from one ambulance, because you stick it in the middle of rural Devon, nobody improves their average response time. And therein lies the moment where you go, those people who sit in CCGs, I have been one, those people who sit in CCGs are just stupid because they cannot understand the simple things that I understand really well. Where do you put your ambulance? This is what goes on in the health service. Currently, if you were sat in NHS England, you'd be thinking about the demand projection going forward that we need 1,000 to 2,000 extra beds in hospitals each year. That tells you a lot about what commissioning is like. Firstly, the new money doesn't pay for that number of hospitals. I mean, just divide those beds by, divide that number by how many hospitals you need and think about how much money it would take to build them. So we're all dealing with the prospect of how do you solve that problem without building those rows of new beds. It also tells you that the currency that anyone wants to use to express demand is going to be based around a hospital. It's going to be based around, I can tell you the number of beds. The currency is not how many community practitioners would we need given the funding growth. It's not how many GP practices, it's not how many GPs. The core currency we have is based in hospital. And in fact, we define everything that doesn't happen in hospital, the 97% of healthcare, as out of hospital, defined around the building where some small amount of stuff happens. And in that moment, I have spent hundreds and hundreds and thousands of hours worrying about A&E response times, cancer targets, everything that happens in hospital. I can't tell you the number of escalation calls I've sat on where we worry about those kind of things. I can tell you that I think I do remember when I was in Yorkshire once having a conversation about investing in MS services. And I don't think it makes me a bad person. I'm just reflecting you are not big enough in the world of CCGs and commissioning to attract attention when this stuff dominates everything that they talk about. So a commissioner is designed to achieve this, right? They are designed to achieve the triple aim. Unfortunately, if there's no money, what you look for is how do I achieve the same level of outcome from less money? So although I can still, hand on heart, say I'm going after the triple aim, the first thing I'm looking for is what's the business case that can reduce resource while still achieving the same outcome. I haven't got money to go at what I wanted to do, and I did do in that beautiful period when we had money in CCGs at 9-10% growth a year, which is, where do I want to put this money into the psychological therapies surrounding cancer pathway? What a great time we used to have doing that kind of stuff. But at the moment, it is in how do we do stuff for less? So if you want to make a case to a commissioner or to your hospital, the first thing, the top of the list would be, is what you're doing, is the innovation going to allow us to spend less on your service while getting the same outcome? That's like the first line. And if not, can your innovation show that it's going to save me hospital beds? And we've heard some of this stuff, like 77,000 So the next line, could we invest in NMS service and save money elsewhere in this hospital and improve outcomes and experience? Well, we could get to the next line, which is, if we invested in MS services, we could save in our system. That requires 3 or 4 different chief executives to come together around a proposition, because that's in different parts of the statutory accountability system that we have. Could we invest in MS services and save money elsewhere in our local NHS and care system? Can we make that case? And finally, can you do any of that really easy? Because I'm not going to give you much resource, because you are really small in all of this, and I've got a limited amount of people who can help unlock this kind of stuff. And so if you can't do that really easy, even though I can make the case for the 77,000, if it's not like 100 times 77,000, when I've got an income reduction target of 35 million, it's unlikely that your 77,000 is going to reach my desk and I'm going to be interested. If you're getting into doom and gloom just before lunch, I promise you there's better to come. This is the future of data. So we are moving away from commissioning. Commissioning was invented because we had long waiting times. We had transactions in elective care that we were rubbish at. I managed 2-year waiting lists. The first time I went into commissioning, I was managing 2-year waiting lists. And we created a payment structure that incentivized us to reduce that, and it's worked really well, actually. You can get a cataract operation really quickly in this country. It is absolutely useless as a payment structure when the biggest issue we need to solve is around chronic condition and long-term care and non-elective care. And that's why we're moving from how we have funded payment by results style healthcare to integrated care systems, the vanguard of the future, integrated care systems. Full disclosure, Optum Runs is a big healthcare company, employs 125,000 people delivering healthcare, and a lot of that is in accountable care systems, which, as you know, some people think is the privatization of the NHS. I believe in integration is the savior of everything that we do in public sector systems. Optum uses analytics to drive its healthcare revolution. This is a slide from a patient in this country, and what it is doing profoundly is at patient level, it is linking data across everywhere that this patient touches the healthcare system. It is linking every single contact this person has had in primary care, social care, community, inpatients, outpatients, electively, A&E. Everywhere we collect data, we are the best healthcare system in the world for having structured data. Our IG passion stops us from doing much meaningful with it once we've got it. But this is where we are going. If you have this, right, if you could see this, you don't need commissioners. Because if you had this, it is patently obvious what needs to happen here. So, if you can't see this 56-year-old woman and the colours aren't quite standing out, she has seen her GP 109 times in the last 2 years. Just so you understand how the economics work, that GP practice has got paid about £200 for that 2 years' worth of care for those 109 appointments. It is no wonder that GPs get a bit annoyed when you say, could you just try a bit harder? You're not really trying hard enough. And they're relying on the fact there's loads of me who don't go to the practice very often to offset the fact. In reality, they get paid about £2 for each time this patient walks through the door, who is one of the most complex people they have to deal with. And what's happened here, despite seeing this woman 109 times over 2 years, is she got admitted with a £9,000 admission in February this year. This is a renal failure patient. And you will notice, if you can look carefully at colours, in the 2 months before that, primary care didn't see her at all. Even more reason why the hospital is about to turn around and say she should never have come into hospital using one of our beds, and you didn't try hard enough because you never saw her for the last 2 months. 109 times I saw her. How much harder do you want me to try? But if you gave that to a bunch of clinicians and took me out of the equation as a commissioner, if you did that, you would all find a way to say, if you were in a GP practice, you'd see her every week on a planned basis, right? You'd invite her in for coffee every week, once a week, because you would change the way you deliver healthcare from that slide. You would also, if in the hospital, say to the general practice, I'm going to pay you some money to see her twice a week, because our healthcare system would be better if I get away from the fact that you're contracted in a certain way and looked at how we would incentivize this system to better deliver the triple aim. It's all on that slide. You can add air quality data. You can add anything into a big data set like this that could prove what it is about this patient. If you aggregate this up and you add 5 years of history and you add really powerful algorithms and millions of records of research data into an algorithmic stratification tool, you can find out all the events that go on that would predict what's going to happen to this patient in the future And then you would say to primary care, when somebody turns up like this, do this to them. Not go spot loads of things. When they turn up like this, do this to them, because we know from all the data we have linked together like this, that those practices who do that cost us 5 times less than those practices who don't do that. So I'm going to pay you. I'm going to incentivize general practice to do the job that I want you to do, which is looking after patients. I put it here because I'm just stalling for time while you consider what would it look like if you had that information for every patient in your service. What does that look like? And what would you do when you are staring in the face about how the system is treating patients and how you could reduce variation from that kind of data? So that exists, right? This is, in this country, people are linking this together. If you got that, you take commissioners out of the equation and you create a provider network that is going to respond to the integrated care needs of that individual. So this is the bit that I've been working with Jeremy for a couple of years, and whilst also sorting out him and the team, we also talk about a lot about how would you develop your service regionally, nationally. What's the thing? And that beautifully written, really impressive document about brain health and time matters is fantastic. And I got to the end of it, and my accountant brain in me said, and what's the number? Are you asking for an investment to improve outcome, or is there a business case that would show investment to deliver triple aim outcome and overall save money? And this question, do you hit a triple aim if I invest in you, or are you going to be a cost? And that's a really difficult moment in the 10 years that span this moment, either side. It's really difficult if the answer is the bottom one. And why the answer is you more than it is relying on commissioners, because if it is the bottom one, your journey is more about how you operate. But this is where, let's understand politics. I signed a contract on an independent sector treatment centre in York because I was told in no uncertain terms that the Secretary of State for Health was going to announce those independent sector treatment centres. This is made up, this bit, for the sake of who's recording. The Secretary of State for Health was going to announce the opening of those treatment centres. And I could either sign that contract, which I knew would cost our system money. I could either sign that contract, or I could watch that announcement from outside the NHS by the end of next week. And in that moment, you have a choice. And I didn't sign the contract to save my job. I signed the contract knowing the job wasn't going to get saved because I'd already told them we were going to run out of money eventually. The point was, in that moment, I took a choice about there is now a treatment centre in York that is treating patients. It is the politics of that opened the treatment centre. It wasn't because I, as a commissioner, sat there with need and understood all that I'd learnt and delivered. Can you get to the point where you can say something like, for every £1 we spend on therapy, treatment, intervention, services, for every £1 we spend, we can save this many minutes or hours? What is that rallying number about what you could do if you spent that £1? What that means for an individual, the wonderful stories that you have, what does that mean for an individual? But more importantly, if you want to make the case, what does that mean for society? Because I passionately believe I have no proof, and I am surprised that I haven't come across the proof, that there must be a case in here about what the public sector purse is saving as a result of your investment in service. What's the saving to the additional tax that we can take in this country because people keep working? What's the saving from the reduction in the benefit system? What's the saving to the whole of how this public infrastructure works? I can't find anyone who can tell me that number. Despite all the millions you spend in drug companies on researching drugs and therapies, the money on the health economic basis for what you do, I would then, and overall therefore, there's a saving of 1 plus something if we did that. And the bit about politics is find some young thrusting politician who's in the right arc, who is going to want to write a manifesto that has some of that kind of stuff in it. Because the other thing you have in your favor, your numbers are actually really, really small. So the total that you're going to ask for, I know it's $250 million. Some of the numbers we look at in commissioning are staggeringly big. If you wanted a politician who wanted to make a statement about doing something amazing that was going to save them money, that would change the world, that is a relatively small number. and I've not seen the marshalling of that argument. I am one of those idiotic people in CCGs who has been interviewed on local television 1 week to explain why we were going to stop prescribing gluten-free products to people with celiac disease, and we were going to reduce the availability of orthopedic operations for people with BMIs in excess of a certain number. I sat there, quizzed horribly by a nice person from the southwest of this country about why that was a terrible thing to do, and the last question being about, are you doing the same to drug addicts? You know, that's that moment when you get a horrible question. So I defended, as a rational commissioner, why we were doing it, because we were protecting services for the most vulnerable in society. And there is an evidence base about what we were doing. I was back there exactly 1 week later on the same sofa, defending why we had completely reversed the policy and why that was a really sensible decision. Which was a harder interview. I have to tell you, I got much more trouble. My wife thinks that people on the internet are really nasty as a result of this interaction. I don't work in the NHS anymore, there'll be a reason. What happened between those 2 dates? This is made up again. What happened between those 2 dates? We were told that a politician had put down an early day motion that was going to be debated at a certain time in the House, and if we hadn't reversed our policy by that time, there would be consequence. And that's politics. For all of the work I had done with all of these wonderful GPs, coming up with a policy, working on the evidence, marshalling all of that about why this was the best thing to do in the appalling situation we found ourselves having to save £30 million. We'd done all that work. I'd been on the telly, I'd taken the flak, and it was politics that turns that round. And so whilst I passionately believe in commissioning, I've been in commissioning since the last millennium. I've been involved in, from the very first wave of primary care groups and primary care trusts and CCGs. I think the case is more about you, and I think the case is more about politics. And I think you have an amazing story. I think there are some, look at the strengths of what you have. The smallness of your specialty is a weakness or a strength. It depends how you want to marshal the argument. And I am here because the work I do with Jeremy and the team is some of the most remarkable stuff I've ever been involved in. It's been a real pleasure to talk to you.